Hello, and good morning. Welcome to the last Wednesday morning rounds of this academic year. I would like to introduce Melissa-Fay Lepage, our last year cardiology residents, or maybe I should say a fresh cardiologist. Yeah, I see three more there. And all passed their Royal College exams. What a beautiful thing. And again, on behalf of Melissa, I would like to thank to all our last year residents for their contributions to the cardiology rounds. Melissa will present a talk about beyond the monitor from standardized to precision care in the CICU from a quality perspective, quality improvement perspective. If you are joining online, please submit your questions in the chat box or Q&A, and then I will address them with Melissa after the talk. Thanks.
Thank you. So good morning, everyone. So my name is Melissa. For those who don't know me, I'm I guess, graduating cardiology resident here at the Heart Institute. And next month, I'll be starting a critical care fellowship here in Ottawa, alongside a master's degree in health quality at Queen's University. The title of today's presentation is Beyond a Monitor, from Standardized to Precision Care and the CICU. The phrase beyond a monitor is intentional. As you'll hopefully gather by the end of this talk, it's both a description of where we've come from, but also an argument about where we might need to go. I want to start with a patient story of someone that would have been very familiar to the founders of the CCU. Let me bring you back to 1965. 50-year-old steel worker, previously healthy, develops substernal chest pain, presenting with anterior STEMI. On hospital D2, he develops ventricular fibrillation. His bedside nurse recognizes the rhythm, initiates CPR, and delivers a shock, successfully restoring sinus rhythm. His treatment? The standard therapies of that era. Strict bed rest, tele, morphine, oxygen. He's discharged on day 21, alive. In many ways, that was the kind of patient the CCU was originally designed for. A relatively homogeneous disease process, a predictable set of complications, and a dominant threat, lethal ventricular arrhythmias. The early CCU succeeded because it did one thing remarkably well. It provided continuous cardiac monitoring, allowing life-threatening arrhythmias to be recognized and treated before they resulted in sudden cardiac death. Now let's contrast with a patient many of us have encountered in one form or another. 65-year-old woman with non-ischemic cardiomyopathy and chronic kidney disease. She presents with acutely decompensated heart failure and SCI-C cardiogenic shock. She requires intubation, vasopressors, and renal replacement therapy. A few days later, she develops ventilator-associated pneumonia and now has more of a mixed shock physiology. By day 5, we're discussing ECMO candidacy, surgical feasibility, and goals of care with a multidisciplinary team at bedside. This is not simply a sicker version of the first patient. It's a fundamentally different clinical problem. Multiple organs involved, and even more importantly, competing physiologies. No single protocol that addresses all of this simultaneously. No obvious answer, and often a genuinely uncertain outcome. These two patients frame the central question of the talk today. There's no doubt our population has evolved and the therapies available to us have expanded. And the modern CICU now manages a level of complexity that would have been almost unrecognizable 60 years ago. But now the question becomes, if the patients we care for have changed dramatically over the past 60 years, have our quality systems evolved at the same pace? My argument is that they have not, well, at least not completely. Many of our quality systems still rely on standardized syndrome-level protocols, frameworks that were designed for a relatively homogeneous population, not for the 65-year-old female we just talked about. The central idea I'll explore today is a more precision approach to understanding our patients, so matching treatment to the biology driving their illness might help bridge that gap. And here's how we're going to get there. We'll begin with how the CCU evolved into the modern CICU and the challenges posed by today's population. We'll then explore precision phenotyping, the infrastructure needed to support it, and what a practical path might look like moving forward, including here at the Heart Institute. So let's get started. To understand the modern CICU, we need to go back to the 1960s when the CCU first emerged. In less than a decade, a series of remarkably simple ideas transformed the care of patients with acute myocardial infarction. In 1961, Wilburn first described the concept of a dedicated CCU. That same year, Julian articulated the key ingredients that would make that work: continuous ECG monitoring, dedicated beds, specially trained nurses with immediate access to defibrillation. 2 years later, Wilburn and Field operationalized the concept, establishing the central CCU as a practical clinical entity. Importantly, these advances also introduce a theme that, as you will see, continue to be present throughout today's presentation. The most successful healthcare innovations often create new challenges. By solving one problem, one revealed the next problem. And the final milestone of this slide, the Killip and Campbell milestones, offer an early glimpse on that phenomenon. In 1967, Killip and Kimball reported their first 2 years experience with 250 consecutive MI patients treated in a dedicated CCU. In patients without shock, CCU care produced roughly a 20% absolute reduction in mortality, from 20% to 7%. Quite a dramatic result. That same paper also gave us the well-known Killip classification, which remained validated and widely used nearly 60 years later. But buried in the same data set is a paradox I want you to notice. Shock mortality remained remarkably high. In fact, it even appeared a bit worse, not because the CCU failed, but because the CCU successfully prevented arrhythmic death, leaving behind the most physiologically complex patients. So in other words, standardized care produced transformative gains for the patients it was designed to help, but shock remained largely unsolved. It was one of the earliest demonstrations that, in a sense, success created its own complexity, and the complexity that would eventually define the modern CICU that we now know. Over the next several decades, the CICU evolved in response to new technologies, new therapies, and new patients' population. Think about hemodynamic monitoring, reperfusion, MCS, advanced heart failure therapies. Each advance expanded what cardiac critical care could do, but also expanded the ranges of conditions, potential complications, and decisions that clinicians were expected to manage. The modern CICU was not created all at once. It was really built layer by layer. What began as a unit designed to monitor arrhythmias gradually became a unit responsible for managing multifactorial shock, respiratory failure, multi-organ dysfunction, and increasingly complex technologies. And with each layer, the CICU became more capable, but also more difficult to standardize. The CICU we practice in today bears little resemblance to the CCU of the 1960s. Aging patients, increasingly diverse diagnoses, growing overlap with multi-system critical illness, and outcomes that have struggled to keep pace with rising acuity despite major therapeutic advances are all reflection of that transformation. And we'll return to each of these themes in more details over the next few slides. But for now, I really want you to focus on the bigger picture. What we're seeing now is really just the tip of the iceberg. And now let's look beneath the surface. So who is actually in our CICUs today? The important point is not any individual statistics on this slide, it's the pattern. Across multiple cohorts and registries, today's CICU patients are older, more medically complex, and increasingly affected by non-cardiac illness. The Critical Care Cardiology Trials Network, the 3CTN, and the Mayo Clinic data tells a remarkably consistent story. As you can see here, a large proportion of our patients are now over 70 years old, and a substantial minority of our patients is above 80. Why does that matter? Because many of the tools we routinely use to estimate risk in critical illness, including Apache and SOFA, are known to perform less well in older population, meaning that we may be systematically underestimating risk in a population that now represents a growing proportion of our CICU. And age is only part of it. Look at the comorbidity burden. Diabetes in roughly 1/3 of patients, chronic kidney disease is nearly 1/4, and active malignancy approaching 1/10. We're a long way from the 58-year-old male steelworker that we discussed at the beginning of the talk. Increasingly, we're caring for patients that are not only older, but frailer. Over the last 2 decades, frailty amongst ICU patients increased from 37 to 45%, while multimorbidity rose from 54 to 72%. And contemporary CICU cohorts, nearly 2/3 of patients have at least one major non-cardiac chronic condition, with mortality increasing stepwise as comorbidity burden accumulates. In other words, complexity isn't the exception anymore, it's the norm. The complexity becomes even more apparent when we look at why patients are being admitted to the CICU in the first place. Today, ACS accounts for roughly 1/3 of primary CICU admissions. Not surprisingly, heart failure is another major contributor, accounting for 19% of primary admission, but then up to 40% when secondary diagnoses are included. Surprisingly, roughly half of the CICU admission are for conditions that are neither ACS or heart failure. Everything from arrhythmias to valvular disease to aortic syndromes to pulmonary embolism and cardiac arrest. And often, as we know, several of these problems can coexist in the same patient. But perhaps the most important shift isn't diagnostic, it's physiologic. Holland and colleagues found that half of the CICU patients developed at least one extracardiac organ dysfunction, such as respiratory failure, kidney failure, or sepsis during admission, each of which was independently associated with worse outcomes. And these problems are becoming far more common over time. Jenser and colleagues examined more than a decade of CICU admissions. And the finding I want to highlight is this one. Non-cardiac organ failure doubled from 28% to 56%. By the end of the study period, more than half of the CICU population were experiencing significant dysfunction outside of the cardiovascular system. In other words, the modern CICU is no longer managing isolated cardiac disease. It's really increasingly caring for patients with multi-system critical illness. And what about outcomes? So the Katz paper from Duke, which included nearly 30,000 CICU admissions over 17 years, found that overall CICU mortality was essentially unchanged. But while the Katz data gave us a population-level view, the Mayo data shown here provides a more granular look at what's happening underneath. So if you look at panel A, mortality amongst patients admitted with ACS has declined substantially, approaching 1% for uncomplicated cases. But for most other cardiovascular diagnoses, unadjusted mortality changed very little over time. Panel B here shows mortality trajectories for critical care diagnoses such as sepsis, respiratory failure, and organ failure. And we see that unadjusted mortality has declined, but remains very high, roughly between 15 and 40%, depending on the diagnosis. But there's a very important distinction here. After risk adjustment, mortality improved within many of those subgroups. In other words, we are genuinely getting better at caring for critically ill patients. Yet, when we look at overall CICU mortality, it remains largely unchanged. The question is why? Because the proportion of critically ill patients increased over time, ultimately masking those within group gains. We're basically just running faster to stay in place. And that gap between therapeutic progress and population level outcomes is exactly why and what makes the modern CICU such a challenging environment for quality improvement. Part of that challenge is that we're increasingly caring for patients with very different physiology and diagnostic process within the same unit, often using the same resources, processes, and structures. One of the most striking findings from the 3CTN registry is how wide the range of acuity is within a single unit designation. Approximately 40% of CICU admission ultimately required no advanced ICU level therapy and no invasive monitoring. And the mortality in that group was very low. Meanwhile, patients with cardiac shock, respiratory failure, and cardiac arrest continue to experience substantial mortality despite decades of therapeutic progress. So this raises an important and uncomfortable question. Are we consistently placing the right patients in the right beds? And as our population has evolved, the limits of a one-size-fits-all approach became increasingly apparent. And that's what we'll go to next. Before we talk about precision care, I want to make one thing very, very clear. Protocols do work, and they deserve enormous amount of credit. As you can see here, the history of medicine is full of examples of standardized approaches saving lives. Whether it's in sepsis, delirium prevention, ventilator-associated pneumonia, or STEMI care, disease-specific protocolized care interventions have consistently transformed outcomes. But the evidence becomes less straightforward when we move from disease-specific protocols to broad ICU-wide interventions. The checklist ICU trial, the largest cluster randomized trial of ICU checklist ever conducted, enrolling more than 6,700 patients over 100 CCU in Brazil, used an intervention that combined daily checklist, explicit goal setting, and clinician prompting. It was shown to improve adherence to the recommended care processes, but it did not reduce mortality. So that doesn't mean that checklists don't work, but rather it may suggest that improving care delivery may not always be sufficient to improve outcomes. It also raises the possibility that broad, process-based strategies may have less impact when applied to a highly heterogeneous patient population. And that becomes particularly relevant in the CICU, where many of our protocols are developed and validated primarily in the medical surgical ICUs rather than in the cardiac critical care setting. So the question is no longer whether protocols work. We know they do. The question is more so whether every patient carrying the same diagnosis benefits equally from the same treatment. To answer that question, we need to look at a concept called heterogeneity of treatment effect, or HTE. When randomized trials report treatment reduce mortality, the results represent an average effect across all enrolled patients. But patients within a trial are not identical, as we know. Some may benefit more than what the average suggests. Others might benefit less and even be harmed. This variation in response to treatments is basically what we call HTE. Think back to our 65-year-old patient with mixed cardiogenic and septic shock. She's exactly the kind of patient who could fall through the cracks of average treatment effects. Competing physiologies coexist, competing treatment priorities emerge, and the average result of any one trials become very difficult to apply. One of the most instructive demonstrations of this concept was a simulation study that was done by Awashina and colleagues. They simulated 10,000 hypothetical RCTs in two scenarios. One that the treatment benefit was large enough to produce a positive trial, and one where it was dilated enough to create a negative one. But in both cases, the treatment had a real biological benefit and a constant treatment-related harm. So if you look at the figure on the right for the positive trials, if you look at first glance, you could just say that this is a positive study. Overall mortality is lower in the treatment group than in the control group. But look at the deciles. Treatment increased mortality in the lowest risk patients while producing substantial benefit in highest risk patient, a nearly 60% absolute mortality reduction in those who stood to benefit the most. In the figure of negative trials here, the same phenomenon plays out, but differently. High-risk patients still benefit, but those who benefit are offset by harm amongst low-risk patients. So the headline of the study could read, this therapy just doesn't work. But what's actually happening is way more nuanced. High-risk patients do benefit, low-risk patients are harmed, and those opposing effects cancel each other out when averaged across the entire study population. So the key principle is this. A neutral trial is not necessarily the same as an ineffective treatment. A positive trial does not necessarily mean that every single patient benefits equally. And I want to be clear, these figures don't prove that phenotyping is the answer, but they do highlight a quite fundamental challenge that patients enrolled in the same clinical trial may not derive the same benefit from the same intervention. And to consider how this can play out in practice, I want to turn to ARDS. That is one of the field that is furthest ahead in this work. The FACT trial randomized over 1,000 patients with ARDS to liberal versus conservative fluid management and found no significant difference in 60-day mortality between the two strategies. More than a decade later, Famous and colleagues used latent class analysis to identify two biological subphenotypes, hypo and hyperinflammatory. When they re-examined the clinical trial through that lens, they found the significant treatment by phenotype interaction with a p-value that's way below 0.05. So the original trial was not wrong in itself. Their average treatment effect simply obscured potentially meaningful differences in treatment response between biologically different subgroups. And for many, this became the proof of concept for precision care in critical illness. So what do we mean here by precision care? I think it's important to be precise because these terms get used quite loosely. Precision care recognizes that patient carrying the same diagnostic label may differ in meaningful ways. So rather than treating everyone identically, it seeks to identify difference in biology, prognosis, and treatment response, and use those differences to guide clinical care. In practice, that means asking ourselves three questions. Who is most likely to benefit? Who is biologically different? And what deeper biological mechanisms can we potentially target? Cardiac shock provides a useful case study because it illustrates nearly every challenges that precision care is trying to solve. Despite decades of research and major advances in supportive care, mortality remains extraordinarily high. And many RCTs, as we know, have failed to demonstrate a consistent benefit. Think about routine balloon pump use in IBP Shock 2 trial, Impella CP and Impress, and early VA ECMO and ECLS shock. They all failed to demonstrate clear mortality benefit, despite a strong physiologic rationale. Obviously, there's one very important distinction that we have to mention. Danger Shock, that was published in 2024, did demonstrate a mortality benefit with Impella CP. However, unlike prior trials, it enrolled a more narrowly defined population, only STEMI-related shock, excluding severe RV dysfunction and persistent post-arrest coma. Whether patient selection fully explains the result is uncertain, but you do wonder if narrower patient selection may itself account for at least part of that signal. And that possibility, I think, becomes even more apparent when we understand that or remember that cardiac shock is not a single disease. A patient with AMI-related shock is not the same patient as one with acute on chronic heart failure leading to shock, or secondary shock from valvular disease, for example, even though they all technically carry the same diagnostic label. They all differ in physiology, trajectory, and often outcomes. For example, in one contemporary registry, in-hospital mortality for AMI-related shock was estimated at 41%, while mortality for acute on chronic heart failure-related shock was only 25%. The challenge is that our current classification systems often do a much better job as understanding severity than they do at understanding or describing biology. The SKY classification was a major advance over the past decade. It gave us a common language, and it consistently identified patients at higher risk. But severity is only one dimension. The 2022 SKY update recognized this and proposed a three-axis framework: shock severity, phenotype and etiology, and risk modifiers. What remained missing, however, was a practical way to define biologically meaningful phenotypes at the bedside, using data that's already readily available. And that's where the work of Zweck and colleagues becomes particularly important. So Zweck performed a machine learning derived phenotyping study using 1,900 patients from two international cardiogenic shock registry. They asked a remarkably practical question. Using only routinely available clinical data, can we identify biologically distinct patient subgroup? The input variables were just 6 routine lab values available within the first few hours of virtually any CICU admission: white blood count, platelet count, GFR, ALT, bicarb, and lactate. And from those 6 variables alone, they identified 3 reproducible phenotypes with markedly different clinical characteristics and outcomes. The first phenotype, the non-congested group, was more younger patients, fewer comorbidities, a relatively preserved kidney function, and lower filling pressures, with more in-hospital mortality ranging between 10 to 28%. And then the cardiorenal group, usually older patients with CKD, anemia, significant congestion, and obviously renal dysfunction, with their mortality between 32 and 45%. And then the cardiometabolic group. Think about severe metabolic derangement, elevated lactate, liver injury, right-sided congestion, and low cardiac power output. The mortality ranging from 52 to 56%. And these findings were externally validated in an independent cohort of nearly 800 patients, including all-cause cardiac shock, not just AMI, CS. So think about what that means. 6 routine lab values, 3 distinct patient groups, and nearly a 5-fold difference in mortality from the non-congested to the the cardiometabolic phenotype. And once we accept or realize that these are biologically distinct patients, the next question almost asks itself: should we expect the same therapy to work equally well in the same in the same group or in all 3 groups? And the data suggests that probably not. Zweck and colleagues followed up with analysis of MCS outcomes stratified by phenotypes. In the cardiorenal phenotype, MCS use was associated with significantly higher in-hospital mortality with an odds ratio of 1.82. No significant associations was observed with either the non-congested or cardiometabolic phenotype. I want to be careful here. This is all observational data, so it's only hypothesis generating. It's not practice changing on its own. But conceptually, it is exactly what HTE looks like in practice. The same device, different biology, and different outcomes. It reinforces why patient selection matters at least just as much as device selection itself. Zweck and colleagues recently revisited the danger shock trial through that lens. In this post-hoc analysis that is still in press, all 355 participants were retrospectively assigned to one of the three Zweck phenotype. The 180-day mortality was 33% in the non-congested, 47% in the cardiorenal, and 69% in the cardiometabolic phenotype. But the more interesting observation was that the apparent treatment effect differed across phenotypes. The strongest signal was in the non-congestive phenotype, with little signal in the cardiorenal. Importantly, again, this interaction was not statistically significant. So these findings remain hypothesis generating. But I think this study illustrates an important shift on how we interpret clinical trials. Danger shock is often discussed as a positive trial, which is true. Yet increasingly, trial results might need to be viewed more in a more nuanced lens than just positive versus negative. In fact, many of the subsequent discussions surrounding danger shock have centered exactly around that question, rather than asking only if therapy works on the average population. We're slowly beginning to ask ourselves whether its effect differs across biologically distinct patient subgroups. So that doesn't mean that every subgroup analysis is meaningful, but I think it does mean that trial results should no longer be interpreted as like purely binary fashion. Up to this point, we've focused on phenotypes. Endotypes attempts to go one step further. Rather than describing how patients differ, they seek to identify the underlying biological mechanisms driving those differences. Susi and colleagues applied the concept of cardiogenic shock using a panel of admission biomarkers. They identified four endotypes that were subsequently validated across two prospective cohorts and three completed cardiogenic shock RCTs. They went a step further by characterizing each of those subphenotypes using additional mechanistic circulating markers, including IL-6 and procalcitonin, to demonstrate that each subphenotype reflected a different underlying biological signature, if you will. And not only was the biomarker different, but the distinct 28-day mortality or survival trajectory was also different between the proposed endotypes. Importantly, also, endotype assignment was found to improve prognostic discrimination beyond SKY staging alone. I do want to note an important caveat, though. The biomarker panel that was used in the SUSI study was measured from stored samples using research-grade assays. So the authors themselves emphasize that future adaptive trials should be designed alongside the development of bedside biomarkers assays. So in other words, the biology is compelling, but the implementation pathway is not yet established. By this point, you're probably wondering whether phenotyping requires some exotic test or technologies that are potentially unavailable in routine practice. And in many cases, it really doesn't. Most of the data needed from phenotyping already exist in the modern CICU. Routine labs, hemodynamic monitoring, echo, and increasingly biomarker panels all provide complementary information about risk, physiology, congestion, and underlying biology. The challenge is not really data acquisition, it's data integration. It's how to really combine those signals into a coherent phenotype that can inform clinical decision-making at the bedside. Gianzoli and colleagues illustrated what happens when multiple data streams are considered simultaneously rather than in isolation. Using a combination of labs, hemodynamics, and echo variables, they identified 5 cardiogenic phenotypes with distinct, again, mortality trajectories. Importantly, no single variables defined the groups. The apparent phenotypes only became apparent with all those data streams were integrated together. So the key message is that cardiac shock heterogeneity may not reside in any single biomarker or variable alone, but rather in any combined interaction between all those potential variables. This brings me to a clinical decision-making model that by the purpose of developing, I find quite useful as a kind of like an organizing principle. It's a classify, monitor, and adapt model, which is emerging from the cardiac shock literature and will serve as the conceptual framework, or I should say foundation for the QI framework we'll discuss a bit later. So the first step is to really to classify, so understand who the patient is when they arrive to the CICU. So I'm talking severity, etiology, ventricular phenotypes, and labs for phenotype assignment. Each provide a different piece of the puzzle. Second is monitoring. Cardiac shock, as we know, is a dynamic process that evolves over minutes to hours, not days. Zweck and colleagues recently published a serial phenotyping study, including over 7,000 patients, and in 78% of patients, sky stage evolved within 6 hours of admissions, and 77% changed phenotype over that same 6 hours. So a static snapshot at admission is simply not enough. And the 2025 ACC expert consensus formalizes this by offering precise guidance in terms of what we should be doing from a monitoring perspective. And there's a reason why this matters. Like prognostic discrimination improved when sky stage and phenotyping were considered together at each and single reassessment. 2 patients with the same sky stage can have remarkably different risk profiles depending on their phenotype. So looking at stage without phenotype or phenotype without staging, each leave information on the table. And then I want to add one more layer to this. As pictured on the top left of the screen, monitoring extends beyond traditional macro circulatory variables that we clinically or often routinely use. Restoration of systemic hemodynamics does not always rely into restoration of tissue perfusion. That concept that we know as the loss of hemodynamics coherence, so the disconnect between those macro and more micro parameters, was found to be independently associated with worse outcomes. And this has generated interest and direct assessment of the microcirculation. For example, sublingual capillary monitoring, although those approaches all remained largely investigational at present. And third, adapt. So as severity, phenotype, and physiology evolved, management strategies also need to evolve. Precision care requires continuous reassessment and adaptation throughout the clinical course, not surprisingly. The challenge, of course, is that delivering this type of care consistently requires more than individual clinical judgment. It requires a whole system capable of supporting classification, monitoring, adaptation, and learning. Traditionally, research and QI have been viewed as separate activities. Research generates evidence and QI implements it. The two operate sequentially and often in silos. Precision care kind of challenges that distinction. What the National Academy of Medicine calls a learning health system describes a cycle in which clinical care, data, research, and improvement continuously inform one another. So clinical care generates data, data informs research, research produced evidence, and evidence improves care. But importantly, QI initiatives are then applied to both clinical care and research infrastructure, strengthening each and generating new evidence opportunities for learning. And the cycle repeats itself. And now the question becomes whether we can build that same clinical framework into the CICU. And this is what brings us to the next section. If the science is emerging, why hasn't precision care become routine practice? Nearly a decade ago, Katz and colleagues published a paper identifying barriers to implementation to maturation of critical care cardiology, including those related to care delivery, research infrastructure, education, and workforce development. Most of those barriers were system level rather than disease level, and they remain highly relevant today. The challenges are no longer simply identifying better phenotypes. It's building systems capable of recognizing them, learning from them, and translating that knowledge into consistent bedside care. So if the barriers are largely system level, then the question now becomes, where should we focus our efforts? For the purpose of this discussion, I've grouped the key priorities into two broad categories: more foundational domains and learning system domains. And we'll explore each of them over the next few slides. Importantly, these are not the only priorities or challenges facing the modern CICU. However, there are four recurrent themes in the literature, and I would argue four essential building blocks for bringing precision care into routine practice. So priority one is workforce and heart teams. Precision care requires expertise and coordinated decision-making. Dedicated cardiac intensivists and multidisciplinary shock teams are increasingly recognized as a structural requirement for high-quality cardiac critical care. And this is more than a theoretical argument. Papoulos and colleagues found that shock centers had lower risk-adjusted CICU mortality, used invasive hemodynamic monitoring more frequently, and were more selective in their MCS utilization. While, again, observational, these findings support that workforce and heart teams are a key priority. The second is organizational culture. Precision care also requires a shift in how we think about quality improvement. Traditionally, we would ask, did we follow the protocol or the checklist? And although, again, that question remains very important, precision care adds a new question on top of that existing foundation. Did we match treatment to the biology and physiology of the patient in front of us? The third priority comes to registries and data infrastructure. If we want to identify phenotypes, measure outcomes, and understand treatment response, we need standardized data collection at scale. Collaborative data collection platforms such as the 3CTN, Vanquish Shock, and the AHA cardiogenic shock registries are all beginning to provide that foundation. The fourth priority, which we'll detail more in the next few slides, is trial infrastructure. Precision care requires more than data collection. It requires the ability to generate new evidence. And building that capability means embedding clinical research into routine care and creating infrastructure that can efficiently evaluate new therapies and new treatment strategies. Before discussing how phenotype-guided trials might be designed, it's worth asking where the field is already investing its research efforts. A recent review by Patilla Lopez characterized the current cardiogenic shock trial landscape, grouping them into three main domains as pictured on the slide. My goal today is not to review every single trial individually. Rather, it's to highlight a common theme. Across all domains, investigators are increasingly moving away from a one-size-fits-all approaches and towards more targeted questions about which intervention would be most appropriate for which patients, at what time, and under which specific physiological circumstances. And whether explicitly phenotype guided or not, many of these studies reflect a broader shift towards precision care, to better patient characterization and more precise patient selection. What remains missing, however, is this infrastructure to support that approach systematically in real time. The phenotyping studies we've reviewed so far have been largely observational and, again, hypothesis generating. The next challenge is determining whether phenotype-guided intervention actually improve outcomes, which ultimately requires prospective randomized trials. Traditional RCTs face two major limitations in that context. Scientifically, as we already covered, heterogeneous patient population may obscure meaningful treatment effects within specific subgroups. Operationally, however, once enrollment closes, the trial infrastructure is basically dismantled, and each new therapy requires building a whole new trial from scratch. So master protocol designs offer a framework for trying to do this more efficiently. There's the basket trial, for example, that tests a single therapy across multiple diseases that share a common biological feature. There's the umbrella trial that divides a single disease into biologically distinct subgroups that receive different therapies. And finally, the adaptive platform that takes the concept even a step further. Instead of building a new trial for every single clinical question, it creates a permanent infrastructure that can evaluate multiple therapies at the same time. New intervention can be added, ineffective ones removed, and treatment allocation adjusted as evidence accumulates. So in other words, the trial learns as it goes, and the infrastructure remains in place, ready to answer the next clinical question. So we've covered a lot of ground so far. We've seen how the CICU has evolved and how heterogeneity has challenged traditional approaches to care. And now the question becomes, what it would actually take to operationalize precision care in the CICU. And this is my attempt to answer that question. A proposed QI framework organized around the model of structure, process, and outcomes. Structure is the key foundation. These are systems that make precision care possible. Tiered CICU designation, multidisciplinary shock teams, etc. Without these, precision care remains an academic concept rather than a clinical reality. The center column should look familiar to you. It's basically the classify, monitor, adapt model that is just translated into a clinical workflow. And at the center of that cycle is continuous data integration. It's like the connective tissue that links assessment to decision clinical making and allows information from multiple sources to be translated into action at the bedside. And finally, outcome measurements. I won't explain or go over those in details, but it's important to know that those should include assessing whether the system is learning and improving over time. So here, I want to be explicit about what the intervention actually is. The intervention is not phenotyping itself. The intervention is building infrastructure, workflows, and culture that allow precision care to occur consistently at the bedside. So for the interest of time, I want to go over briefly what we could think about for the next steps. Earlier this year, Dr. Matthew and the colleagues at the MUIC, we published an invited perspective piece aimed to reimagining the CICU from scratch, informed by everything we've learned about critical care cardiology in the last two decades. The central illustration from a paper is intentionally aspirational. It asks what the CICU might look like if we fully embrace the principle we've discussed today. And it's organized around three pillars: clinical care, research and quality, and education. And what I want you to appreciate is that many of these capabilities we've discussed are already here at the Heart Institute. We already care for a high acuity population, including patients with complex shock through an established MCS program. We already have multidisciplinary shock team activation that is embedded in routine clinical practice. And importantly, this approach has been shown promise locally. A before and after study published by our own colleagues demonstrated that implementation of a cold shock program was not only feasible, but also was associated with improved long-term survival in patients with cardiogenic shock. I was hoping to be concrete about like how I'm proposing this these 4 steps could look like using a 4-step roadmap, acknowledging that this is not a definitive strategic plan. It's simply one possible path forward. Determining whether what's feasible, valuable, and worth pursuing would require a much broader discussion involving many of you in this room. But the step 1 would be to measure, so understanding our own CICU population, leveraging registry data that we already have. Step 2 would be phenotyping, as we discussed, and see how they perhaps relate differently to outcomes. The step 3 is learn, so expanding registry participation and data integration, and eventually potentially electronic health records, linked dashboards, and decision support tool. And the step 4 it's really the transition to research the bedside infrastructure, as we discussed with the building the structure for adaptive or platform research trial. So what might a precision shock trial look like? This is very important to know that this is a conceptual design exercise. The specific therapeutic domains shown here are purely illustrative. The domains and interventions themselves are less important than the architecture that supports them. But in this hypothetical example, patients with SCI-C or D shock would be classified at admission using real-time phenotyping strategy. And then patient would be randomized across multiple therapeutic domains simultaneously, with treatment allocation adapting as evidence emerge. So where would I start? I will go briefly, but my first step, along with my critical care fellowship and my master degree in QI upcoming, my first step personally will be to characterize the cardiogenic shock population at the Heart Institute, again leveraging multi-center data that we have. And also we're in the midst of building our own institutional data set, CardioCore, so leveraging that, those tools will be instrumental. Eventually, I'm hoping to apply the ZWEC and Ginzoli phenotyping frameworks and see if there's any variation in treatment patterns and outcomes. And the long-term goal would be to move beyond phenotyping description and towards quality improvement. So see how those insights from phenotyping can guide quality improvement initiatives in future research. I want to close with one more thought. At the end of the day, precision care is a means, not an endpoint. Even if we match therapies to perfectly to the biology, we must still ask what outcomes actually matter. Survivorship research and shock have reminded us that survival alone is not sufficient. Patients want to go home. They want to spend time at home with their families. The goal is really not just survival itself, it's a life worth surviving for. Before I take any questions, I just want to acknowledge the people without whom this work would not have been possible. So Dr. Matthew, Dr. Parlow, Dr. Golian, Dr. Froschel, whose mentorship, guidance, and support have been instrumental to this presentation and also all the work behind it. And a special mention to my colleagues at MUIC for their support in the invited perspective paper. Thank you very much for your attention, and I'm happy to take any questions or comments.
Right, that was an excellent presentation. Any questions from the audience? Any comments? Everybody understood it very well. So I just, I think according to the presentation, AI will be a very important part of this, I think. Is it close, like it's coming, or near future, or when do you think it's going to be implemented into the clinical care?
That's a very good question, and it's very important because as we and again, like the perception of a monitor is that although it was a single ECG on the CICU in 1967, now it's the monitor that we see is like, you can imagine, as a bunch of integrated clinical data. So it's a lot of information coming at you at once. So we need AI and machine learning to integrate those data into organized frameworks. And this is coming. I mean, they're looking into leveraging like electronic health record system and see how we can pool data together in order to make it more digestible for clinicians and hopefully eventually apply it directly to phenotyping. So I think over the next decade, we'll see a lot of evolution in that sphere.
Melissa, that was really outstanding. You know, one of the things that always strikes me when I hear these, you have to get a different acronym. CS stands for cardiac sarcoidosis. But one of the things that always strikes me about these talks is just how, you know, we're just unable to nudge the needle and improve mortality. Even danger shock is a very fragile trial. And it's part of the problem, not just we're just getting these patients too late, and they're just too late. And if you think that is a part of the problem, how do we get them earlier?
Mm-hmm. And that's a very good question. And I think it comes down to education as well. Education of the patients, education of the community centers around us to recognize when the patient is sick and sick before it's too late. So I think it requires collaboration amongst the our community, both in cardiology, but also in family medicine, internal medicine, and etc. And also, it also comes down to prevention, right? So educating our patients to make sure they recognize, like, first prevent potential reversible signal for deterioration, but also recognize the potential alarms where perhaps they should present and seek medical care. Then that comes into a broader question in terms of how do we adapt our healthcare system to respond to that demand, and that in itself could be a single thesis in itself. So to answer your question, I think there's multiple spheres that would be needed to really be successful and identifying our patients in shock early.
Dr. Boxar has a question. Great talk. You showed data that an inflammatory phenotype in CS, cardiogenic shock, performs poorly. Do we do any biomarkers routinely to phenotype inflammation in our patients?
So that's a very good question. There was the SUSI data that looked that had the 4 subphenotypes, including inflammatory phenotypes. But again, they looked at those phenotypes and tried to understand which very specific biologic signatures might impact how patients respond differently to treatment. But as I mentioned, those are for now not readily available to the bedside. I mean, the SUSI trial, like that described some inflammatory phenotype, used something called bio-ADM, for example, just to identify the 4 phenotypes, which is not something that's readily available to order. So it still requires a lot of thought process into first, how can we potentially develop new phenotypes that use bedside clinical data, or how can we try to facilitate the implementation of those more specific or novel biomarkers into something that's more easily available in daily clinical practice?
Yes.
Sorry, I gotta run, but fantastic talk, Melissa. Thank you. I would encourage. I love the focus on quality and everything that you're thinking about and moving forward with. I'd encourage connection with the quality team here as well. to educate them on some of the things that you've talked about. And you talked about data, and yes, you're working on a CardioCore module. We're also looking at how we advance and improve CardioCore. And there's also the data platform, Archimedes, that the Institute has built. So I'd encourage connecting. I don't know if this is a potential avenue for data and data analytics for the critical care work, but it could be. And so I'd encourage connecting with Jody Edwards and team and so on for that as well. So well done. Thank you.
Great. So that was excellent. Thank you very much. That was the last talk of the academic year. We'll see you next fall. I am now preparing the list for the next year. If you have any recommendations, or if you want to talk about your expertise, just let me know, and have a nice summer.